everyone, and welcome to this episode of Patient Pulse. This month, we're joined by a longtime friend of NATF, Dr. Elliott Antman, and he will be chatting with us about atrial fibrillation, the risk of stroke, and the role of oral anticoagulants in atrial fibrillation. Dr. Antman is a professor of medicine at Harvard Medical School and a senior investigator in the TIMI study group, which is an academic research organization dedicated to studying treatments for heart disease. Dr. Antman is also a senior physician in the cardiovascular division at Brigham and Women's Hospital and is a past president of the American Heart Association. Thank you so much for joining us today, Dr. Antman. Take it away.
Thank you very much, Aviva. It's a great pleasure to be here. And this is a very important topic that we're talking about, atrial fibrillation, an increasingly common problem since it's seen more frequently as our population ages. So today we'll be discussing a patient's guide to atrial fibrillation. I do receive some research grants through my institution for studying new strategies for caring for patients with atrial fibrillation. Everything we're talking about today will be on a very general educational level, and there'll be no specific drugs mentioned that need to be brought to your attention. So here's an overview of what we will be talking about today. What is atrial fibrillation? We need to understand that. What causes atrial fibrillation to develop? What problems does it cause for patients? And what are the major treatment options for atrial fibrillation? That's quite a bit to cover, and we'll sum up everything we've discussed with the key points for you to remember. So let's begin with the question, what is atrial fibrillation? So I'm showing you here a diagram of the heart, and on the top left-hand corner of the slide is the normal situation. There are 4 chambers in the normal human heart. So the top right-hand chamber is called the right atrium, and blood moves across the tricuspid valve, which is right here, into the right ventricle, then goes out to the lungs where it picks up oxygen and comes back from the lungs into the left atrium through the pulmonary veins, which are shown here on the side of this diagram. There are actually 4 pulmonary veins, and only 2 of them are seen in this picture right here. The main pumping chamber of the heart is the left ventricle. Now, what's key for us to understand, besides the anatomy here, is the electrical activity of the heart. The normal or native pacemaker of the heart, that is the place where the heartbeat actually begins, is right up here in the top right-hand corner of the heart, this little yellow oval structure. This is called the sinus node. And there's an electrical discharge that occurs normally. And that's 60 to 100 times a minute, and that's our normal pulse. The electrical discharge, which starts up there, then proceeds, as shown in the blue portion of the diagram, across the top chambers of the heart, stops in the central switching station in the middle of the heart called the AV node, and then goes down some very specialized fibers shown here in yellow. And that's how the electrical impulse gets to the ventricles. So normally the heartbeat begins at the top right-hand corner, sweeps in an orderly fashion across the top of the heart, then to the bottom of the heart. And you can actually see the wavefront of electrical activity moving from the top of the heart down towards the bottom of the heart. And so 60 to 100 beats per minute in a regular metronome-like fashion is the normal heartbeat. This is sometimes called sinus rhythm or normal sinus rhythm. Now let's compare that with atrial fibrillation. In this diagram on the right-hand side of the slide, you can actually see several white star-like areas of the heart. And this is meant to depict areas where rapid firing is occurring. And so there are many electrical events occurring throughout the top portion of the heart, not just the single initiating one in the normal situation. Now, actually, there can be quivering movements of the top portion of the heart, which may be firing 300 to even 400 times per minute. Fortunately, our central switching station in the middle of the heart filters some of those, and only a portion of them actually make it to the ventricles. But it's irregular. And typically, the heartbeat in a person who has atrial fibrillation unless they're receiving any medicine, is between 100 and 150 beats per minute, and it's very irregular. There's no clear pattern to it. So patients typically complain of a racing heart and a sense of palpitations where the heartbeat is irregular. What causes atrial fibrillation to occur? Some possible risk factors for atrial fibrillation, which is sometimes abbreviated AFib or AF, are shown here. There are certain heart health factors. That could be a person having had a prior heart attack or some form of heart disease, high blood pressure, diabetes, or difficulty with breathing while they're attempting to sleep. This is referred to as sleep apnea. There are certain behaviors that can also bring on atrial fibrillation, and they may be associated with excessive alcohol use, cigarette smoking, and interestingly here, prolonged athletic conditioning. Some elite athletes can actually have atrial fibrillation. Perhaps you know someone in whom that is the situation. What problems does atrial fibrillation cause? There are two big ones that are shown on this slide. On the left side are the symptoms that a patient might have: a sense of a racing heart, fluttering or palpitations, some shortness of breath, lightheadedness. So this is what a patient may experience and should make them think about the possibility that they may be in atrial fibrillation. Now, a very important concern when a person is in atrial fibrillation is that the blood is not moving in a regular, organized fashion, and it can be likely to form a clot. A small clot could form inside the heart and could fly out of the heart, and it could go to an artery in the brain and block the blood flow to a portion of the brain. And that, of course, could produce a stroke. And here's a simple thing for one to remember, an acronym called FAST: face drooping, arm weakness, speech difficulty, time to call 911. So remember FAST as possible warning signs of a stroke and the need to get medical attention quickly. Now, how do we as healthcare professionals diagnose AFib? We listen to the patient's description of their symptoms, we listen to their heart, and most importantly, we take an electrical recording of the heartbeat. This is called an electrocardiogram, sometimes abbreviated ECG, sometimes abbreviated EKG. So ECG and EKG are synonyms, and they refer to the electrocardiogram. I don't want to get terribly detailed about what we see on the electrocardiogram, but I do want to call your attention to this regular rounded waveform that you see appearing before every sharp waveform. The small rounded waveform is the normal electrical pattern from the top portion of the heart during normal heart rhythm. You can see that that's basically absent when a person has atrial fibrillation, and there is an irregular heartbeat. Each of the sharp complexes is one heartbeat. So in addition to the heartbeat being faster, it's irregular, and that's what we look for on an ECG or electrocardiogram. So what do we do when a person has AFib? Well, we think about whether or not we want to restore the heart rhythm to normal. And there are two basic ways that we can do that. One is called an electrical cardioversion, which provides an electrical jolt to the heart. Typically, the patient lying on a table is given some light anesthesia, so they are drowsy and a little bit asleep. And then some electrical paddles are placed on the chest, and an electrical jolt is delivered to the heart, and that causes the normal heartbeat to start up again. Sometimes we prescribe drugs called antiarrhythmic drugs, which tend to stabilize the heart rhythm. And they can actually cause the heart rhythm to flip from atrial fibrillation back into a normal one. So if you have atrial fibrillation, it's possible that your healthcare providers may talk about an electrical cardioversion, or they may talk about antiarrhythmic drugs to bring your heart rhythm back to normal. And then there will be a conversation that you'll want to have with your healthcare providers where you focus on the major treatments for atrial fibrillation. We've divided them into two strategies. One is called rhythm control, where we do everything we can to try and establish a normal heartbeat and keep it there. We want to get the heart beating again like it did in that earlier diagram that I showed you. And we'll talk in a few minutes about the various things we can do to achieve rhythm control. We want to keep the heart rhythm normal. The other major strategy is to say we're going to not make an attempt to keep the heart rhythm normal. We're just going to keep the speed of the heart under control. And this we call a rate control strategy. So on the left, we try and keep the patient's heartbeat normal. And on the right, in certain situations, we say that's just not possible to do or too risky. And we'll allow the patient to stay in atrial fibrillation, but we'll control the speed of the heart. No matter which of these two strategies we pick, because of the risk of a blood clot forming, it is highly likely that a patient with atrial fibrillation will receive a prescription for an oral anticoagulant. These are sometimes colloquially referred to as blood thinners. Now, they don't actually thin the blood. They just make it harder for a blood clot to form. We'll talk a little bit about the various drugs that might be considered here. Now, we have a scoring system that tells us how likely a person is to have a stroke if they develop atrial fibrillation. Now, you may hear your healthcare provider refer to the CHADS-2 VASC score, and each of these letters here actually stands for a certain phrase. So, for example, the C stands for congestive heart failure. The H stands for hypertension. The A stands for age greater than 75. The D for diabetes. S is for stroke, prior transient ischemic attack or stroke. The V is vascular heart disease, age 65 to 74. And then the sex category, females get 1 point. So if you have one or more of these factors in the CHADS-2 VASC score, the score is added up. And if you have a score of 0 or 1, most of the time, doctors and nurses feel it's unlikely that you'll need to take an oral anticoagulant. Anything above that, we start to say the risk is concerning and we want to give you an oral anticoagulant. So the CHADS-2 VASC score is a very important tool that we use to measure a person's risk of a stroke. How do we reduce the risk of a stroke in atrial fibrillation? On the left-hand side are the drugs that we would consider. These are oral anticoagulants. Our old standby is warfarin, comes in different tablet strengths. And as some of you may know, there needs to be regular blood testing for something called the International Normalized Ratio, or INR. And that helps us determine whether we need to go up on the dose or down on the dose to keep the degree of anticoagulation in a desirable range. Over the last several years, there's been a dramatic advance in medicine in that several new oral anticoagulants called NOACs or direct oral anticoagulants, DOACs, have been introduced into clinical use. And your healthcare provider may wish to have you use one of those instead of warfarin. Now, all of these oral anticoagulants reduce the likelihood that a person's blood will form a blood clot. And of course, that means that there could be an increased tendency to bruising or even in some instances, bleeding. And on rare occasions, that bleeding may be a concern, and it would be a situation where we would feel that it's not wise to continue with the oral anticoagulants, but we have to do something to reduce the risk of a stroke. And fortunately, there's another option, a mechanical option, which we reserve for that situation. This is a portion of the top left-hand corner of the heart called the left atrial appendage. And what you see is specialists have inserted via a catheter a mechanical plug, which is blocking the connection between the main portion of the left atrium and this little windsock-like area called the left atrial appendage. A good many of the clots that form inside the heart form in this little windsock area. If we can somehow block them from moving out of the left atrial appendage into the left atrium, then we can mechanically reduce the risk of a blood clot forming and getting out into the circulation. Now, what about rhythm control for atrial fibrillation? I mentioned earlier that there are some drugs called anti-arrhythmic drugs that may need to be taken several times a day to try and keep the heart rhythm normal. I'm sure that many of you who have had atrial fibrillation or know of someone who does have atrial fibrillation have heard about a procedure called an ablation. Essentially, what happens in an ablation procedure is the patient is taken to a special procedure room called an electrophysiology laboratory, and a catheter or a series of catheters are placed in the heart under a fluoroscope, and there are small electrical treatments given to certain portions of the heart. Typically, this is an electrical burn with radio frequency energy. Sometimes extreme cold is used. But the notion here is to create an area where the electrical activity can no longer come out and capture the main chamber here, the left atrium. So an ablation procedure can reduce the likelihood that atrial fibrillation would occur, depending upon the age of the patient, how long they've been in atrial fibrillation, how big their left atrium is, what their underlying heart condition is, will determine how likely an ablation procedure will be successful. Some patients need to have a second procedure if the first one is not completely successful. Now, for rate control for atrial fibrillation, that's where we keep a person in atrial fibrillation and we give them medications to try and increase the filtering capacity of that central switching station in the middle of the heart called the AV node. And there are two classes of drugs. One are called beta blockers, for example, metoprolol or toprol or atenolol or tenormin. These are drugs of the beta blocker class, and they will increase the filtering capacity so that a fewer number of the rapid quivering movements from the top portion of the heart actually make it to the bottom portion of the heart. Sometimes we use a different class of drugs called calcium channel blockers. Sometimes we use these together in carefully titrated doses. And as I mentioned, as long as we can keep the heart from beating too fast, many patients with atrial fibrillation feel perfectly fine and they can go about their daily activities and have no significant problems. So let's sum up what we talked about today. What are the key points to remember about AFib? I pointed out that it is an increasingly common problem because it's seen more frequently in patients who are older. And since our population is aging, we're seeing more and more patients with atrial fibrillation. Fortunately, many treatments are available. And because of the many different conditions that can bring on atrial fibrillation and the many different treatment options, a comprehensive approach is best. It's good for you to be informed as a patient so that you can have conversations with your healthcare team that will allow you to weigh the various options. So you need to know the facts. You need to stay in touch with your medical team. That's essential because we need to know whether or not the initial strategy that was selected for your care is actually working. Do we have to switch? And finally, whenever we agree with you on a particular program, if there are medications involved, it's very important that you take your medications as prescribed. Because if you don't do that, then we don't really know whether or not our strategy was working or whether it wasn't working. And if it wasn't working, was that because it wasn't the right strategy for you, or was it because you didn't actually take the medications as originally prescribed? So I hope this information has been helpful to you. Lots to talk about with atrial fibrillation. And I'm sure we'll be back to go through the details of some of the treatment options in the future. It's been a great pleasure to present this information to you today, and I hope that it will be the kind of information that will stimulate your thinking if you are diagnosed with atrial fibrillation. Thank you very much.
And thank you so much, Dr. Antman. That was a great overview, and you really helped explain what atrial fibrillation is, how it affects the body, and you certainly helped highlight why it is an educational priority for NATF. So we truly appreciate your time and expertise. And to our listeners, we hope you'll join us next month for our final webinar of 2020. We'll be discussing how to safely exercise after having a blood clot. Thank you so much.